course directors, Professor Dr. Ajay Mahajan sir and Professor Dr. Kamal Sharma sir. As you all know, is our esteemed faculty for the entire Cardio PG Masterclass program right in front of you. For today, I have the honor of introducing Professor Dr. Ajay Mahajan sir, who's a senior consultant and interventional cardiologist and HOD of KEM Mumbai. We also have Professor Dr. Kamal Sharma sir, who's a senior interventional cardiologist at UN Mehta Hospital as well as SAL Hospital. We also have Dr. Anita Saxena ma'am, who's the Vice Chancellor of PBD SUHS Rohtak, Haryana. And finally, we also have Dr. Nageshwar Rao, who's Chief Pediatric Cardiologist at Rainbow Children's Heart Institute, Hyderabad. I now hand over the session to our esteemed director, course director, Professor Dr. Kamal Sharma sir. Dr. Sharma, over to you, sir.
Hi, good evening, everyone. It's always a pleasure to be associated with academics. I thank Professor Dr. Ajay Mahajan sir for joining me as the course moderator and moderating the whole session. But we have honored to welcome Professor ma'am, Dr. Anita Saxena ma'am, and also it'll be pleasure to have Dr. Nageshwar, who will be taking the case first. And then with us is Dr. Keyur, who's a resident. I think, Keyur, you're a third-year resident at KEM Mumbai?
Yes, sir.
Yeah. And he'll be presenting a case of eisenmenger syndrome. And then after his presentation and the viva that we have, Professor Dr. Anita Saxena ma'am will give us an approach of how to deal with a case of eisenmenger, and then also something to touch upon about a CAT study to look for borderline cases of severe PH where the operability can be decided upon. So thank you, ma'am, for agreeing to do the same and honor us with the same. So over to ma'am and Dr. Ajay Mahajan, over to you first, and then we can have probably the case presentation.
I think today's session is for my learning also. Professor Dr. Saxena and Dr. Nageshwar Rao, both are the big name. They are the world authority in this particular subject. So I want to hear from them only, and I want to learn myself also, and for all the students also. So today is the feast, academic feast.
Okay, Dr. Keyur, if you're ready, you can start with the presentation.
Yes, sir. Good evening, everyone, all esteemed teachers. Thank you for the opportunity to have this case presentation in front of all my teachers and great academicians. So I'll start with the case. History. My patient is a 22-year-old female hailing from Nanded, Maharashtra, that's mixed diet, informing being patient herself and her parent, mother and father. Presented with chief complaint of dyspnea on exertions for past 2 months and fever since last 2 weeks. And the presenting illness, the recent onset dyspnea on exertion, which is recent onset gradually progressive dyspnea, exertion in the form of fatigue noted while going to college, which is around 1 kilometer distance from our house, and this was noticed during 6 months of pregnancy. She could just a minute. So she could complete her ordinary daily activities without dysfunction, discomfort, which suggests she was in NYHA functional class 2, not associated with orthopnea, PND or rest symptoms, no angina, syncope, pre-syncope or giddiness. She visited her obstetrician in view of this dyspnea complaint, who referred her to a cardiologist. And after doing the test, she was told that she should consider MTP in view of increased maternal risk. This MTP was done at 24 weeks after consulting with 2 other obstetrician and gynecologists, and her symptoms worsened after the procedure was done, so that she couldn't even take self-care activities in the hospital without discomfort. So in that means she progressed from functional class 2 to functional class 3 post MTP, and she was referred to our hospital in view of worsening of symptoms. Currently, after starting the treatment at the hospital, she feels better and she is at present again in NYHA functional class 2. Fever. A patient also gives history of fever since last 2 weeks, which is high grade associated with chills. It subsides on taking oral medication, and there are no such episodes of fever for last 4 days. It is not associated with cough, expectoration, abdominal pain, burning, nutrition, headache, throat pain, running nose, or earache. I would like to club the past with and the parental history together for better understanding of the case. So the patient is a second by birth order, born by full-term normal delivery. At day 3 of life, mother was told that child has 2 holes in the heart, and the VSG as parents are telling, and was advised to follow up and they were told that there is a high chance that these will be taken care of by itself and no intervention would be required for this, and should not started on any medications for the same. Thereafter, during first year of her life, she was admitted 3 times to the hospital, every time with fever, cough and fast breathing. Each episode she used to remain admitted for around 4 to 5 days, where she used to receive IV medication, and after feeling better, she used to discharge. She used to get discharged. In the second year of life, she was admitted twice for such complaints, and thereafter, no such admission episodes were reported by the parents. During this time, she also had there was poor weight gain during this time, but was not associated with such cycle or fluid discoloration or spell or feeding abnormalities or forehead sweating. After 2 years of age, patient lost to follow up with the doctors, and then again at the 10 years of age, she complained of effort intolerance, and she noticed that she couldn't cope up with peers while playing and while going to school. But this time it was not associated with fluid discoloration or syncope or other symptoms. So she was again shown to the doctor because they were told that there was a hole in hearts, and that this time doctor told that the holes remained and they were big enough that this time a surgery would be required. So open heart surgery was done at the age of 10 years, and report was uneventful according to the parents, and thereafter the patient had remained asymptomatic, and again she did not follow up for further till the current episode. Obstetric history, she is para 1 MTP1, currently day 30 of PNC. LMP menses are not restarted since the gestational amenorrhea. Diet, personal, social history, the appetite is reduced in view of current admission. Apart from that, nothing significant. To summarize, my patient is a 22-year-old female with history of recurrent LRTI in infancy, and in the second year of life, 5 such episodes in total over duration of 2 years, requiring admission and IV medications for treatment, with no history of cyanosis. And again, there's a surgical BSD closure as said by parents. Now presented with progressive dyspnea for last 6 months and fever for 2 months and fever for last 2 weeks. There's a typing error. Sorry. Examinations.
Can you please wait? We just wanted to know from the history few more points.
Yes.
If you can go back to your, I think slide number 2, where you said dyspnea in the form of fatigue. I didn't understand that expression of yours. Yes, recent onset, gradually progressive dyspnea on exertion in form of fatigue. What does that mean?
She used to take breaks.
No. Is there dyspnea or is there fatigue? These are 2 different symptoms.
Yes, ma'am. She tells that she gets breathless and she takes rest for that. Thereafter, she again continues. Again,
you haven't answered the question. You think dyspnea and fatigue are the same things?
No, and there are different. Dyspnea is subjective.
So what is her symptom? Dyspnea or fatigue or both?
Ma'am, I would keep both, ma'am. She categorically tells that she has to.
Okay, you are not getting the point I'm making. Don't repeat. I am only asking you, writing something like dyspnea on exertion in the form of fatigue is absolutely not understandable to me. And it will not be to your examiner also. So you have to choose what you want to say. She might be getting fatigued, but is it dyspnea which allows her not to continue her walk, or which does not allow her to continue her walk, or is it fatigue? So you have to differentiate these 2. Number 2, you did not talk about her education and occupation.
Ma'am, she's a college student.
She's married, pregnant, but college, still going to college.
Yes, ma'am. Yes, ma'am.
What is she studying in college?
Commerce.
Okay, so she's a student, but you're saying she's married also, and obviously she's got a baby. I mean, she was going to have a baby.
Yes.
This should have come in your first slide, where you're talking about her age or her, her informant and all that. The very first slide which you showed.
Yes, ma'am.
Okay. And the next question I have for you is that she's been operated at 10 years of age, where some VSD closure, some open heart surgery has been done.
Yes, ma'am.
She was told that she has a large hole.
Yes, ma'am. At that time.
Did she undergo a cardiac catheterization pre-op?
No, ma'am. I had asked regarding any previous
You have to say this. You have to say this. This is very, very important, because as we will go and discuss this, at 10 years, somebody with a large VSD may be inoperable or borderline operable. So majority of these cases will undergo a cardiac catheterization to assess operability.
Okay.
So this is a question. This is the point that you should write as a negative point. Otherwise, we will not even understand whether you know this fact or not.
Okay, ma'am.
Okay. Now
Yes.
let us see from your history, what do you think are the various possibilities before you go to the examination? You can go to the last slide of summary.
Ma'am, as per history, patient is having congenital heart disease with increased pulmonary blood flow, presented as repeated respiratory tract infections in the infancy as itself, without a history of cyanosis.
No, what are the possibilities now at 22 years? What are the diagnostic possibilities based on history?
Ma'am, the acute nature of the history, the recent history being acute, I would like to consider, with history of fever, I would like to consider now possibility of infective endocarditis, because of which her acute worsening of the symptom is there. Probably during the surgery itself, there is a possibility that one of the defect might have not closed, which is caused, or probably when acquired post closure, there can be a possibility of acquired RV outflow tract obstruction in this patient. Another possibility being, ma'am, that maybe they would have created another atrial septal defect to allow decompression during RV decompression and closing the VSD. Yes, sir.
I would like to, go one by one.
And idiopathic PH developing later in young female, again, I would like to keep that as a possibility.
Okay. So your first diagnosis, infective endocarditis, you are not keeping IE along with the other diagnosis. Your first diagnosis in isolation is IE.
Ma'am, in association with a residual.
See, it will always be good if you make a slide of possibilities after history, because many examiners are very fond of asking that. What is your thought process? So,
Yes,
have you got a slide?
Yes, sir. Yes, sir.
Can you show us
good
the
evening.
slide?
I'm sorry, came
Hi.
late.
Hello,
Because,
Nagesh.
good evening, everyone. Just
Hi,
a
good evening,
very
Dr.
quick
Nageshwar.
comment, ma'am. Is it okay? Very quick comment.
Yes, please.
Yeah. So, ma'am, whatever discussed is very pertinent to your case. In this case, you have to divide into three important aspects. Is it a sequelae of the case, or is it a residual problem of the case, or is it a complication of the case? So what ma'am said, that you have to divide into whatever you are telling and describe whatever it is. So if you identify these three, what are the residual problems, what are the sequelae of whatever the disease which you are talking, what are the complications which are possible in this, then it is easy for you. So maybe you can follow that track or differential points.
Yes, sir. So the first part is the residual defect, the residual disease. So here the aortic regurgitation associated with ventricular septal defect, and that worsening now can be one of the possibilities.
So you are saying that she had a VSD for which she underwent a closure at 10 years of age?
Yes.
And after that, she has developed AR, or AR has worsened. Does that happen? Does that happen once you close the VSD? Does AR worsen after that? If it was significant at that time, they would have fixed it up at that time itself.
Yes.
This is 12 years later.
Well, relatively less likely, but
why don't you think of common things first? Why bringing the rarest of the rare things first? What, see, she had large VSD. She underwent closure at 10 years of age. She was asymptomatic for almost 12 years. With
Yes.
pregnancy, she deteriorated. She
Yes.
was quite okay before pregnancy, because you are saying breathlessness noted for the first time at 6 months of pregnancy.
Yes,
So
sir.
somebody who was stable, but at 6 months of pregnancy deteriorated. Pregnancy is an exercise sort of, and that's why she deteriorated. So what is the most likely possibility in this scenario? You are saying things like they closed one hole, they created another hole. Those are very, very rare things that happen. Hardly. So
So
somebody
the
with a
effect
large
of-
VSD underwent VSD closure, was asymptomatic for 10 years, had pregnancy and worsened. Very simple, straightforward history you have. Fever comes much later. Fever is
Yes.
later, but dyspnea is first.
Yes, the pH might have been present at the time of surgery itself, which now again is presenting in view of the pregnancy status, sir.
So she was perhaps inoperable, but she underwent surgery.
Yes, possibly.
And the PAH may have regressed to some extent, but it over a period of time progressed. Obviously, she was asymptomatic, she never came to the attention of any doctor.
Yes.
That is the very likely possibility, considering that you kept on saying that 10 years she had a large VSD.
Yes.
Yes, sir.
So if
What
I
are
ask
the
you how
other
many,
problems which
Yeah,
may
please.
progress during pregnancy, worsen during pregnancy in this particular case scenario?
I'm sorry, sir, I did not get the question.
No, are there any other possibilities likely that worsen during pregnancy, second trimester? So one ma'am said very clear that pulmonary hypertension, if it is there, pregnancy time it can be worsened.
Yes, sir.
Your cardiac output and hyperdynamic circulation, that itself can increase it.
Yes, sir.
So what are the other residual problems or whatever it is present can worsen in this during the pregnancy? Sometimes
even-
outflow tract obstructions.
Yes.
you could talk of even acquired if you wish. We
Yeah.
are not necessarily concentrating on congenital heart, but you should know what are the conditions that worsen during pregnancy, mostly in the mid-second trimester, because that's the time cardiac output is maximum.
The stenotic lesions like mitral stenosis or
Very
aortic
good.
stenosis can worsen with pregnancy. And even the coarctation of aorta, basically obstructive lesions, the left side as well as the pulmonary stenosis, if it had been present, can worsen in the as the pregnancy progresses.
What about AR and MR, aortic regurgitation? Because since you were trying to make a diagnosis of aortic regurgitation, what happens to AR during pregnancy?
When usually regurgitant lesions tend to improve with pregnancy.
Right. So you should not have thought of that diagnosis. And again, I really, feel bad when you make a diagnosis of IPH. Why do you want to make a diagnosis of IPH? You hear IPH is in a patient who has not had any cardiac lesion. It's idiopathic pulmonary hypertension.
Yes.
The dictum of medicine is to try and explain everything by one diagnosis, not make multiple diagnoses.
Yes.
And I don't know why you're thinking of LRTI or even pulmonary embolism in your differential diagnosis. I don't know, you've got two columns of differential diagnosis. I don't know which one, are they all together or there's one with something?
I try to segregate as for cardiac causes and non-cardiac causes.
No,
Actually, if you look at the 4 differential diagnoses which you gave on right side, 4 are totally 4 different pathologies.
Yes.
Idiopathic pulmonary hypertension is different.
Yes, sir.
Worsening AR is different. RVOTV is different. Endocarditis. So, is there any possibility in your history that you can come to 1 or 2 understanding?
Considering that the previous surgery was successful as the patient remained asymptomatic, that's why I had kept the diagnosis of now maybe an idiopathic PH would have been developed, sir.
No,
And
can you not have a patient where PA pressure reduces to some extent following surgery and then it starts rising again?
yes, ma'am, that is quite possible.
Why not think of something that can connect with your diagnosis?
Yes.
So I think to me, it's a very clear-cut case based on history. I will make a diagnosis of residual PAH following a large VSD closure at an age where she was perhaps inoperable. That's all. I wouldn't think of anything else, even infective endocarditis, because her fever is 2 weeks, her dyspnea is of 2 months. She's had a MTP, maybe she's got some infection because of MTP and not really infective endocarditis.
Yes, ma'am.
And she's afebrile for 4 days. That's what you said.
Yes, ma'am.
So I think it's a very straightforward case which you are trying to complicate.
I'll improve.
Okay.
Examination, ma'am.
Yes.
Vital signs. Patient is conscious, comfortable, currently afebrile, pulse was 80 per minute, regular, normal volume, no radial or radiofemoral delay. All the peripheral pulses were well felt. Patient had blood pressure of 120/76 in right arm, supine position, that I didn't mention. Respiratory rate of 20 per minute, thoracoabdominal. Saturation of 88% at room air in all 4 limbs. JVP is elevated 4 centimeter above sternal node with prominent A wave. Anthropometry, mentioned the BMI of 21.9, and she is pale, no clubbing, icterus or edema, and sinuses could not be appreciated in view of pallor. She has good dental hygiene, no nail or finger pulse changes. Spine is normal. On cardiac system examination, inspection and palpation, shape of the chest is normal. I would like to club the inspection and palpation findings. The apex is at the left side, fifth intercostal space at mid-clavicle line, localized with medial retraction seen, and LV type of apex. A palpable second heart sound is heard best in the pulmonary area. Grade 1 parasternal heave is present. There is no thrill. A healthy midline sternotomy scar is seen, which is non-tender. No other scars or sinuses are seen. On percussion situs, the liver dullness is felt on the right, and the trough tympani is present on the trough space dullness is on the left. The left border of the heart coincides with the apex, but the right border of the heart is protruding 2 centimeter beyond the right sternal border. And left second intercostal space, there is a dull node on percussion. And on auscultation, first heart sound is normal. There is a single loud second heart sound with maximum intensity at pulmonary area. There are no S3, S4. A grade 3/6 high pitched deep crescendo murmur, best heard with diaphragm, which is not radiating, and no change in bending cord or isometric hand grip. No other abnormal sound or murmur could be heard.
No. Where is this murmur?
Pulmonary area. Okay.
You're not saying. What about breathing, respiration?
Respiratory 20 per minute thoracoabdominal.
No. Any change? See, when you describe a murmur, you are supposed to tell us, no, whether it is increasing or decreasing with breathing.
When no change with respiration.
First, where is the location?
Pulmonary area, sir. I will typing.
Okay.
So second left intercostal space.
Yes.
Okay. All right. This is your summary. Let us see what. Here you are written EDM. Is it an EDM?
Diastolic murmur.
Okay. You have not even mentioned diastolic murmur.
Yeah, decrescendo murmur you wrote.
Could be systolic also.
No, it's a diastolic murmur.
Look, you're missing out on very, very important points when you're describing a murmur. This is not going to go down well with the examiners.
See,
You don't tell us systolic or diastolic. You don't tell us where it is located. And you are just describing some, other areas. The two main points you have missed.
It is a grade 3 diastolic decrescendo murmur in the pulmonary area, best heard with diaphragm, which is not
Generally, it is better not to say pulmonary area, but to say second left intercostal space. In congenital heart disease, pulmonary area may not lie where you think it will.
Yes, second intercostal space.
Okay. I think so much of cross-questioning should not be, it's not a very good thing that we keep asking you questions like this, which are basics.
Why did you do isometric hand grip instead of talking about respiratory change?
Sir, I checked with the respiration also. They said I missed to enlist proper wording, sir. The isometric hand grip was initially one of the differential of AR I had kept to distinguish from AR.
Okay.
I checked for it.
Okay.
All right. So what's your diagnosis?
To summarize the case, it's a
No,
20.
this is okay. Go to your diagnosis.
It's situs solitus levocardia with congenital heart disease of cyanosis with pulmonary hypertension with shunt reversal due to the post tricuspid shunt residual VSD or in sinus rhythm with anemia with infective endocarditis because recent
Why infective endocarditis? Did you tell us about any peripheral sign of IE?
no, ma'am. In the generally, the peripheral signs of IE are not there, and non.
Did you tell us about liver and spleen?
Splenomegaly is not there, ma'am. I didn't.
Show us abdominal examination.
Yes, ma'am. I had done, but I had not mentioned here. She doesn't have hepatospleen.
I think this is really not acceptable. Dr. Kamal and Dr. Ajay, you don't talk about liver, you don't talk about spleen, you don't talk about the location of murmur, you don't tell us whether it is systolic or diastolic. I think an MBBS student can do better. Your abdominal
You should have
examination is
covered, so say basically 10 points of murmur. Those are the basic things, you know, the characteristic of a murmur, where it's early diastolic. Even madam actually did not point out. You just mentioned diastolic. You should have actually quantified at DM level. Are you talking of early diastolic, pan diastolic? Yeah. So I mean, we know that you know, but that's the thing that you need to avoid in the exam. That's what madam is trying to point out. Okay. So these are the common things which we assume as a resident is understood, but that's not how it goes. You have to be very specific and precise when you're talking about description of a murmur, and also quantify your every statement with an evidence. When you're mentioning infective endocarditis, you need to have some presentation beyond fever, or at least effort to dig it out. You know what madam is saying, whether spleen is palpable, whether if you've mentioned it or not, whether liver is palpable, not palpable. You should mention that you have splinter hemorrhages, osseous node, Janeway lesion, not present, absent, anything. You know, you try to look for them. That's what should be quantified. Every statement that you make must have a reason why you're mentioning. That's what madam is trying to say. Okay, so those are some of them. Yeah.
I think I just want to tell him that even in DM examination, your history and physical examination carry lots and lots of value and marks. Nobody will progress to Viva unless you have not done an examination history properly. There's no time, you know, that we give you 1 hour in the exam. And if you're stuck like this, that you're not mentioning abdominal examination, you're not mentioning about liver in a cardiac patient, you're making a diagnosis of heart failure, you've only told us JVP, you did not tell us about liver, you're making a diagnosis of infective endocarditis, you're not telling us about spleen, all those, you know, Janeways and all that Dr. Kamal has just enumerated. I don't think you will go further. You may know any amount of theory, but I don't think the examiner will let you go to even X-ray ECG. You know, making a diagnosis these days is very easy. You do an echocardiogram and you know the diagnosis. That's not the point. Point in, at least in congenital heart, is that you derive, and rheumatic heart as well, that you derive a diagnosis based on your findings, based on your history. If you don't do all those findings, if you don't do physical examination, how will you ever reach the diagnosis?
I will keep in mind.
Now, is this complete diagnosis or you want to add something? So in your surgically created intra-atrial shunt to offload RV, what is missing, or why are you thinking of this diagnosis based on your findings? There are a couple of findings which are against, absolutely against this.
From the finding which is against it is a single heart sound is absolutely against this diagnosis, but considering that the previously only patient was
more than that, single S2, you could even make a mistake. You said grade 1 left parasternal lift.
Yes.
When you have intact ventricular septum, once the cyanosis happens across an ASD or a PFO that might have been created, would RV not be much more hypertrophic?
Yes, ma'am.
So this grade 1 left parasternal heave is against it.
Yes, ma'am.
So I don't know why you kept that diagnosis. And why not? Why are you not thinking of PD at all?
Ma'am, the saturation in all four limbs was equal.
So in how many percentage of PD eisenmenger saturation, you get differential cyanosis? Everybody?
30 to 50%.
So what about the rest? You can say that because patient is giving history of VSD and the mother is telling you that she was diagnosed with, so you can keep VSD from that perspective. But it could be any post-tricuspid shunt. It could be even AP window. It could be AVSD, AV septal defect.
Yes, sir.
But definitely not AST, not intraatrial septum, because when there is a cyanosis in intraatrial septum, small, then the RV has to hypertrophy much more.
Yes, sir.
What about IPAH?
Ma'am, that is possible, ma'am.
But you haven't written it.
Pertaining to the parasternal heave, what ma'am is asking and you are telling, in which subset of congenital heart disease will have significant parasternal heave? Is it a VST or AST or
Yes.
idiopathic pulmonary hypertension?
ASD and idiopathic PH will have a significant parasternal heave as compared to VSD or PDS.
So you want to keep IPH or you don't want to keep?
Ma'am, I would not keep it.
Yeah, you should not keep it simply for the same reason as was just told to you that parasternal lift must be much more, because obviously cyanosis is happening most likely at atrial level. But could there be cyanosis for other reasons in IPAH and not ASD or not atrial septal defect? Could you have some amount of peripheral cyanosis, central cyanosis in patients of IPAH without intracardiac shunting?
Yes, ma'am, it is.
Because of?
Pulmonary opening of the pulmonary,
Opening of?
impaired gaseous exchange. The pulmonary collaterals, intrapulmonary shunting can happen, ma'am. And secondly, because of increased and a severe pH itself can cause desaturation because of the
Because of?
LCO is increased, ma'am.
Sorry, say again.
And then the DLC, the diffusion capacity is reduced in patients with pulmonary hypertension. So that
So does that cause cyanosis? What is cyanosis? Does hypopnea produces cyanosis?
Increased amount of reduced hemoglobin to at least above 5 g% will cause bluish discoloration of the
So
skin.
is increase in CO2 goes with reduction in O2 also in everybody?
No.
So why should primary pH having increased CO2 will cause cyanosis? This is very, very important for you to understand. There is no reason for cyanosis if the CO2 rises. There has to be some shunting either at lung level or at intracardiac level. And collaterals, by the way, will go left to right, not right to left.
Intrapulmonary shunting.
Yes, absolutely. That's the word you use, but you mixed it with so many other words that it got drowned. So please be very specific, categoric. Don't say too many things unnecessarily, which might put you in trouble. You're right, intrapulmonary shunting can produce cyanosis of minor nature in patients of IPH as well.
Yes.
Okay. Dr. Nagesh, you have anything else to ask?
I think that's.
But I wouldn't consider infective endocarditis. And another thing that I wanted to ask you is why the patient is in failure.
Ma'am, see, anemia is
anemia doesn't cause failure. I think that's a misnomer. First of all,
what is the important aspect which causes a heart failure in this patient? What is the major mechanism? Is it a shunt or is it something related to the myocardial function? Do you think if there will be biventricular dysfunction or right ventricular dysfunction, JVP is rise, you are telling?
Yes.
Ventricular dysfunction is possible?
Pregnancy related hyperdynamic state and associated anemia can cause heart failure in this patient, sir.
Heart failure in children are two types. One is a preload dependent heart failure due to large left ration.
Yes, sir.
Second is ventricular dysfunction.
Yes, sir.
In this particular patient, if the patient is in failure, I don't know, I haven't seen the patient, I wouldn't think she's in failure. But if she's in failure, she's likely to be in failure because of ventricular dysfunction, which is a little unusual, but it can be because she's behaving almost like a primary PAH because her VSD is not very large anymore. So it's possible that she's gone into ventricular dysfunction, but anemia doesn't cause failure. I think that kind of anemia now we don't see, 2 gram, 3 gram, we don't see that kind of severe anemia. Otherwise, anemia at 8 gram, 9 gram will not cause failure. So you have to bring in ventricular dysfunction in your diagnosis to explain heart failure, unless you want to say it is because of infective endocarditis. But I would take away infective endocarditis out of this diagnosis because I have no reason to say so. Spleen not palpable, clubbing not present, although clubbing could be there because of cyanosis also, but absolutely no feature of infective endocarditis. History is short. Her dyspnea predates fever. In infective endocarditis, it is dyspnea which comes after long fever. So there's nothing to suggest infective endocarditis. I have no idea why you thought of it. We could go to the investigations, Dr. Kamal, if you agree.
Yeah, sure, Kure. Kure, also, you could have thought of a couple of other things like patch dehiscence. People tend to do fenestrated VSDs these days, again, which has become a fashion, especially in the ASDs. Again, something Madam has already pointed out, and so did Dr. Nageshwar, as to you should know, though the age and other factors are there, you should think and remember and know concepts about phenomena of gazulization. Also, you should know something about why would you think this as a post-tricuspid and why not pre-tricuspid shunt. You should also know Paul Wood series, how many patients were there, what was their mean age. So these are some of the additional questions that are asked in the Viva. So everybody should go through the Paul Wood's original paper, which was published, 727 patients.
Yes,
What
sir.
was the mean age of presentation of in those subgroup of patients, Kevin? So just go through those important papers. Those are some of the additional Viva, but as ma'am said, if you're stuck on the murmur characteristics and infective endocarditis, probably you will not be asked, but for the sake of our all students, I'm just adding list of the things that you may or may not be asked, depending on how you tend to answer the questions. I usually say that Viva is a trick and a psychological game that you play with the examiners. Either the examiner leads you or you lead the examiner. So, you actually speak out, sir, in Wood series, and then examiner thinks, okay, he's got you on Wood series, and he can grill you as to what is the incidence of syncope in VSD, but actually you're prepared for it. So that's the trick you actually need to cultivate. But for that, again, as ma'am and sir said, you need to be precise with the basics first, your fundamentals first. If you're going to fumble in that, your good credit questions like intrapulmonary shunting in IPH would not give you a credit because you've discredited yourself with a characteristic description of a murmur. Okay, Keur, so don't be disheartened. You're doing well. Let's move. If there are no questions, and as ma'am said, we can move to the investigations. Yes, Keur, can you read the ECG?
Yes, sir. This is a 12-lead ECG of the same patient, where we can see sinus rhythm with heart rate of around 100 per minute, with the P waves, sinus P waves, no RA or atrial enlargement. Evidence of atrial enlargement is not present in the ECG. The PR interval is around 160 centimeter, which is normal. The QT interval is also normal. There is the prominent R wave is seen in V1, V2, V3.
Again, I think it's the same problem. You not talked of excess.
Right.
This is the problem. If you don't go systematic, that is what happens. You tend to forget. So please make a habit of being systematic.
Yes,
it might take you a long time, but doesn't matter. If you miss out on something, if there is a murmur, you should, fill in the blanks, timing, location, loudness, pitch. This is how you should do as a student. Otherwise, this is what happens.
There's a right axis deviation
How much?
When the axis is around 90 degrees.
So when is it called right axis deviation?
Beyond beyond 110 degrees.
So why are you calling this as right axis?
And the equiphasic
No, you're right, it is plus 90. I'm not contesting. What I'm contesting is don't call it RAD. Just say plus 90 QRSX, that's all.
yes.
Okay.
Can ECG tell you what now you're dealing with? How would you apply this ECG to you? Think of the kind of shunt or maybe some other etiology or barring the infective etiology, of course. Can that help?
Yes, sir.
In a patient who's already eisenmengerized, can you look and differentiate between a pre versus post tricuspid shunt causing eisenmengerization or no?
Yes, sir. We can, depending on the ECG. The pre-tricuspid eisenmenger usually will have a QR in lead V1, which here we can only see the R where there is loss of Q waves. There is no Q wave rather. So the pre-tricuspid shunt is less likely. Secondly, sir, there is a prominent right ventricle hypertrophy with strain pattern which we can see in the form of ST depressions and biphasic T waves in lead V1 to V3. And by coronary criteria, sir, even V5.
So more important is not that those features. I mean, okay, let me give you a clue. If you have RBBB or a white QRS versus you have a counterclockwise depolarization, can you have a different etiology?
Yes, in the presence of
we discussed that. Madam presented that last time beautifully in the last lecture Madam took, right?
Yes, so
how you can differentiate the three.
Yes, sir. The presence of RBBB and the counterclockwise looping will favor the diagnosis of ASD, eisenmenger, or the ASD with severe pH as compared to.
Can you differentiate pulmonary stenosis from pulmonary hypertension or eisenmenger or severe pH based on ECG? RV hypertrophy of stenosis versus RV hypertrophy of PAH. Can that be differentiated based on ECG? Yes.
Both have a severe pressure overload on the RV. So the presence of Q
okay, in a patient with PD eisenmenger, do you still get persistence of a physiological Q in lateral or volume overload planes, or they do disappear after the pH develops?
Sir, in PDA, there will be presence of Q waves in V5, V6, and lateral receptor Q waves will be present despite being eisenmengers.
Okay.
Same is true for VST also. Okay, so this is simply showing you severe right ventricular hypertrophy, and it probably doesn't help you. Since you have only grade 1 heave, you probably can rule out pre-tricuspid. PAH with pre-tricuspid shunt, it's likely to be post-tricuspid. And depending on the stage at which she is, these Q waves in the lateral just may become smaller and smaller. Therefore, if they're there, they help you. If they're not there, they don't really help you.
Yes.
Okay. X-ray?
Yes. And this is a 12-lead ECG. This is a chest X-ray. EAU, when we can, I would first like the cardiac silogram is mildly enlarged. I would like to say there is the right side, the right atrium is enlarged. It is acquiring more than 2.5 intercostal space in the right precordium, in the right half of right hemithorax, and even the distance from the midline is approximately more than 2.5 centimeters. So there is evidence of right atrial enlargement.
See, distance from the midline we don't take now with digital X-rays because we don't, it depends how big you want to make it. Even this image you can make it smaller, make it larger, unless you have a scale on the side. Some of the X-ray machines can give you a scale on the side that will help you, and it is not 2.5 centimeters, it's 5 centimeters for adults.
Ma'am, the right pulmonary descending artery appears to be.
No. Have you finished with the heart?
No, ma'am. So I was going
So
close.
don't go to pulmonary
No,
arteries.
First, clarify that whatever the cardiac shadow you are telling, enlargement of RAPA, ma'am
Yes.
is asking you criteria in the era of digitalization. So
Yes.
you don't have scale. Is it? It's obviously seen. Are there some other criteria? Okay, then you carry on. Go to next.
The apex is formed by LV. We can see enlarged pulmonary artery marking in the X-ray. Aorta
No. What is enlarged pulmonary artery marking? What do you mean by that?
And the pulmonary base full, basically.
Again, it is not pulmonary base full. Pulmonary base abnormal. You have to say pulmonary artery segment is prominent. Bay is when there is a bay, like in tetralogy. Normal persons don't have bay. Normal person will have no prominence, no bay. So please don't say bay is full. You should say prominent, and this area is called pulmonary artery segment. Okay, which consists of main pulmonary artery and is overlapped by initial part of left pulmonary artery. So this together makes it pulmonary artery segment. If you have read about the surface anatomy of heart, then you would know where left pulmonary artery and main pulmonary artery lies, and this is the area. So you have to say pulmonary artery. This is called PAS. Pulmonary artery segment is prominent. Just use that term. You don't have to say pulmonary artery markings and all that. There's no point of using those terms which you can't define.
Yes.
So now you're done with the heart. What about aorta? Aorta, ascending aorta or arch of the aorta, are they prominent?
No, ma'am.
Okay. This is important because if you were to make a diagnosis of PDA, then aorta will be important. Aorta will be more prominent if it is PDA.
Yes, ma'am.
Okay. Now you can go to the lungs and tell us about the various abnormalities in the lungs.
When the vascular markings, we can see end-on appearing vessels. Although the pruning is not very well appreciated here, but end-on vessels are seen, and the right pulmonary appears prominent.
Actually, right pulmonary artery is underneath the right atrium. If you see carefully, it's quite dilated, but because there is a dilatation of RA, so you're not seeing it. But if you go down, then just near the diaphragm, you can see the branches of RPA.
Yes.
But what is important is that peripheral 1/3 of the lung is oligemic.
Yes.
Which makes it pulmonary artery hypertension.
Yes.
So central plethora, peripheral oligemia.
Yes, sir.
So you can see main pulmonary artery, left pulmonary artery, and right lower pulmonary artery are dilated.
Yes, sir.
So you have disproportionate findings there. Uniform distribution is not there. So central pulmonary artery dilatation and end-on views in the hilar region, and the peripheral, you can see that vascularity is quite significantly low. There are no vessels are seen for this kind of major pulmonary arteries.
Right.
Sternotomy sutures are seen.
Sorry?
Sternotomy sutures.
Yes.
It's
difficulty, but they are there. Yeah. Yeah, right
good.
there.
Nice.
Yeah. Okay. Yeah. Do you have echo or you are
I
going?
will echo next. Next ka khali. Aur ek baar next. Aur ek baar.
Okay.
When selected sutures taken for demonstration, the left hand side top one, the parasternal long axis view of the heart, which with the color compare mode, where we can see there is a muscular VS septal defect, which is shunting bidirectional across the blood. The lower one, we can see there is a short axis view with some haziness in the VSD patch area near the tricuspid valve, and we can see the septum is V-shaped, but the LV function is preserved, ma'am. And Ma'am, the top right, we can see the RV inflow view, ma'am, where we can see tricuspid regurgitation. And in the lower part, ma'am, we can see the dilated pulmonary artery branches with pulmonary regurgitation.
Do you have a proper 4-chamber view?
Yes, ma'am. Next slide.
Okay, all right, fine.
These are the four apical 4-chamber view, and the lower one last is a slight apical more apical angulation. Ma'am, we can see that there are total 2 defects. One of the is across the septum with a serpiginous tract, and in the lower right we can see there is one apical relatively linear defect is present.
Where is the second one? Can you point it out?
Lower one, right lower right. So this
Maybe
is
the last bit.
probably the second one, which is relatively more apically placed and the linear defect, and in the view, the one which are viewed in the other are the relatively larger and serpiginous tract defect.
And just by the side of the serpiginous defect, do you see a mass-like thing? What is that?
And that is
Yes,
probably the patch which with the VSG might have closed.
What
So
is
it is
the method
possible.
of surgical closure? This is called.
Sorry, sir, I didn't.
What is the type of surgery? VST closure. What type of VST closure?
Muscular VSG patch closure.
Correct. There are so many methods. No, number one is perimembranous VST. You do trans RA. You put a patch. In infants, young children, you do tricuspid wall detachment method. Whereas apical VST is below the moderator band, they do a different technique.
Okay.
Is it a RV exclusion technique? It looks like RV exclusion technique where patch is at the moderator band level. Most of the times that will not work sometimes. Because your patch we can see at moderator band level.
Right, yeah.
Yes, sir.
Okay. Anything else?
And here the left we can see the dilated pulmonary artery branches with diameters of 36 mm at the main pulmonary artery and the branch pulmonary 19 and 18 mm respectively. In the right side at the top we can see there is the pulmonary regurgitation and the estimated pulmonary artery diastolic pressure and diastolic jet is around the PR
Tell
jet.
me, is there any significance of trying to get this jet velocity?
The diastolic pulmonary pressures.
Don't you know?
Yes.
What is the systolic pulmonary pressure?
113 millimeters and the lower the tricuspid value.
113.
Yes.
RV pressure is 113.
Yes.
What was the blood pressure?
120.
So
by
can RV not be 120?
Yes.
So if you have a simple blood pressure in front of you, why are you bothered about TR, PR, everything? In this particular patient, 113, anyway, you have to add RA pressure to it, so it will become 120.
Yes, ma'am.
So once you are asked what is RV pressure, just say systolic blood pressure.
Yes, ma'am.
When there is a big hole, you don't have to worry.
Equalization of pressures.
Yes, has to be. You've just seen that there is no turbulence across the VST.
Shunt.
Yes.
Okay. Anything else you have? You were trying to show some CT.
When that was a cardiac PET which was an of fever and we can yes. And
So did you get infective endocarditis?
when the uptake is present at the patch area only, that
अरे भाई infective endocarditis है कि नहीं है?
ma'am, CRP is elevated, but blood culture.
No. In this particular PET scan that you have, you know how
Yes.
much it costs? Do you know how much PET scan
Yeah.
costs? Do you know? How much a PET scan cost? It's a very simple question. Your parents are going to ask you.
Yeah.
You've done an echo, you haven't found any vegetation, you've seen the area of the VST patch, doesn't show any bizarre motion.
What
Fever is
the
of 2 weeks.
modified Duke's criteria and all?
Yes. Does she fit into infective endocarditis?
Duke's, no, ma'am. The Duke criteria is not fulfilled in this.
So why are we chasing a PET scan, which in my opinion will cost at least 10,000, Dr. Nagesh, or maybe more?
No, more than that, ma'am.
More than that.
25,000.
So at AIMS, it costs, I think, 10,000. I'm sure in private, it will be costing almost 1.5 to twice. So, you need to be very discreet in using these investigations just because they are there. Sometimes we do PET in prosthetic valves because in prosthetic valve vegetations are hard to see. But in this particular lady where you've got a 4-chamber, you know where the vegetation will be in case it is there. What's the point of 20,000, 25,000 rupees where you can't even interpret it even now? You don't even know if it is positive or not.
You did not become wiser after that.
Ma'am, it is positive and the uptake.
Is there uptake?
Yes, sir. The scan is positive, sir.
So are you
Okay.
going to treat her for infective endocarditis? How long?
I'm considering the fever and the positive at an elevated CRP level, ma'am. We are treating as infective endocarditis.
So she's going to
What
be in
is
the hospital for
ESR
6
and blood
weeks.
culture? ESR and blood culture?
Sir, ESR was 68, but she was anemic also. Hemoglobin was of 7.8. So
Again, there are some articles which say that ESR doesn't get elevated in anemia. Go and read.
yes, ma'am.
But the fundamental thing I am asking.
When did she undergo MTP?
MTP at the Nanded, at her hometown.
When?
This, as of now, she is day 30 PNC. ma'am.
So is it possible that a fever came after MTP is related to some pelvic infection? Why are we tracking infective endocarditis when we have nothing to suggest? If you had not done a PAT, you wouldn't even be thinking about it, no? It's very likely that wherever she underwent an MTP, because she underwent MTP at 24 weeks, which is rather, towards the later part.
Yes.
Maybe she has infection there. Have you shown her to an obstetrician to see if there is a pelvic infection?
Yes, ma'am. We have taken this. There is no pelvic infection.
How have they excluded?
They did PS and their high vaginal swab has been sent, which is negative.
I wish they were doing an ultrasound before the PET scan, ultrasound abdomen.
It was already done when she was started. Here also we have repeated. There is no evidence of any.
Because I don't see any evidence of infective endocarditis in the echo at least. So here in PET, where are you getting a high intensity signal? Which part of the heart you think is a vegetation?
The septal area is. We had a talk with the nuclear medicine center at our department, at our hospital, and the uptake, the septum is relatively having more uptake more bright as compared to the other parts of the heart.
So tell me, how much is the false positive rate of PET for IE?
I don't know.
And this septum that you are getting, it's possible that the patch that you have is showing that kind of abnormality. No, you have to be very, very discreet. PET has a false positive rate, which is pretty high, 20-24%, if I remember correctly. So people have stopped doing it. In fact, it is no more recommended in the guidelines, except for prosthetic valves.
We had discussed with the.
No, it's okay. I'm not saying that what they're saying is wrong.
But,
it's important for you to know.
It's going to be useful for you to make a diagnosis. That's the important. What is the specificity and sensitivity? Important. But did you look for fundus Roth spots in this patient?
Yes.
Urine for microscopic hematuria.
No, ma'am. There is no other evidence of, and the other scientific evidence are not in the present impression. No nail changes, no splinter hemorrhages, no road spots, no Janeway lesions. No, even organomegaly is absent.
Is she become afebrile after you've started antibiotics?
Yes, ma'am. I mean, after.
So you did not tell us about treatment history also, that means.
It was in our setup, so I did.
No, generally, this is important. No? If you're making rhizoinfective endocarditis, you have to tell us that you started antibiotics on her, and after 72 hours of that, she became afebrile or she started having fever coming down. Those are very, very important facts that you haven't told us.
Yes, sir.
That means she's admitted with you for quite some time now, no? You've already started
Yes.
antibiotics.
Yes.
Okay. All right.
So PET can be, what does PET tell you? PET tells you inflammation or infection.
Inflammation, sir.
Yeah, so that's what ma'am is saying. That's why there is no probable such a strong value to do it and to find out infective foci, which may be so minuscule or small that it can sometimes be false positive or even can be missed, false negative as well.
Yes.
That's why the yields are not so good, especially in a highly vascular structure like myocardium. That's the whole problem. Okay. So do you think you need to cath this patient anymore? You want to cath her? Think about that VSD once you've treated
Yes.
infective endocarditis. You want
Yes,
to cath
sir.
her anymore or you don't want to cath her?
He want to do CAT study, sir, but once the infected and once the
So why do you want to do cath after IE has
Yeah.
been treated? With what in mind you want to cath her?
What is the aim?
the
What's your
increased
aim of
pulmonary, sir, the entire physiology and the elevated pulmonary pressures can be attributable to the level of infective endocarditis as well as anemia. So once
Infective endocarditis, how will that elevate PA pressures?
overall an increase in hemodynamic state and
No.
increase hyperdynamic state will
No, please use your words carefully. There's no hyperdynamic state here.
because of infection.
How will infective endocarditis produce severe pulmonary arterial hypertension? Tell us the mechanism.
Not severe, no, but
Severe enough to reverse the shunt. She's 88% saturating. So it is severe, isn't it?
yes.
So how are you blaming IE to it? Remember, she became symptomatic before she developed fever.
Yes, sir.
So why blame
other way
something
question
that
also is very important. Is infective endocarditis is common in eisenmenger? The shunt which you have right to left shunt, is it possible to have infective endocarditis that commonly compared to restrictive VSD?
No, sir.
So first of all, we are not even sure about the diagnosis of IE. Supposing her IE is not producing pulmonary, there is no IE first of all, even if it is there, it will not produce pulmonary artery hypertension. I think you have to go and read. It doesn't produce PAH. There is a right to left shunt happening across the VSD. Now tell us, do you want to cath her or not?
Yes, sir.
Now for what?
Ma'am, if the pulmonary vascular resistance still falls between 4 to 8 Woods unit, she still
Do you want to kill her or what? I think you are bound to kill her. Somebody saturating at 88%. Why do you want to still go ahead and close the VSD? She's lucky to have escaped that VSD closure. She'll die. She will die. I will show you data. She will die. This is nothing but, trying to kill her, really. As doctors, our first motto is not to harm. I'm very
remember,
thankful to the
whenever you're
surgeon.
asked, sorry, ma'am, sorry.
No,
please.
I said I'm very thankful to the surgeon who operated on her without a cath and left the VSD. I think he's done a very good job of not closing this VSD. Or God has helped her. Now you really want to go ahead and close the VSD or what? Sorry, Dr. Kamal, please go ahead.
Yeah, so I was saying, ma'am has pointed out, and remember just an exam trip again. Whenever you are asked about an invasive procedure, though you have become an invasive procedure, if you answer for yes, you make sure that you've dug your head thrice and come and answer with yes. So you may be asked whether you do an angiogram, whether you'll do a BMV, whether you'll do an MVR. Think twice. Though you may be becoming an interventional cardiologist, our training is to desist you from not doing what is not, avoiding you to do an unnecessary procedure. So usually the answer is no whenever such question is asked. So this is another trick of the exam, that if you're asked, will you do this? Just think, yeah, maybe I'll do if that is there. So you can say, I'll do only if it's the patient is getting enrolled for an eisenmenger study where a cath is required or mandated for a new drug therapy. Those are a couple of indications. Once you have a fully established eisenmenger, that patient does not require a cath to establish a eisenmenger as a cause. So once it's established, it's established.
Could cath be dangerous in these patients? It's also important to cover for them to know that it is not that it is okay not to do. Point is that it's
Why
also
not
harmful.
Why not to go?
It is harmful.
Why cath is dangerous? What happens when you end up?
Do you know that cath in eisenmenger has higher mortality, even a diagnostic cath?
Because they have what? What is their viscosity? What do you inject? What kind of saline? I mean, so you have more incidence of stroke, thrombosis, renal shutdown, bleeds in these patients as compared to a patient who does not have eisenmenger.
So cardiac catheterization in the presence of pulmonary artery hypertension of significant nature and fixed PVR are to be done very, very carefully. In fact, if you read that Pro Kerala registry, which is published from India, they have not catheterized even primary PH patients, which is something that a lot of Western world does. But we haven't done that.
Yes.
So I think cardiac cath, I would say not required. The question is, what are you going to do for her, considering that her IE is not there or has been treated? She's 88% saturating. Is there anything else that you want to do for her before she goes home?
I will start her on pulmonary vasodilators.
At 88%, what pulmonary vasodilator you want to use? Can you tell me any data on pulmonary vasodilator treatment in Eisenmenger syndrome?
The recent guidelines on the pulmonary hypertension, which has come published by EAC in 2022, have recommended to start upfront the dual therapy of a PDE5 inhibitor with endothelin antagonist. Probably the
no. Are we talking of Eisenmenger syndrome, or are we talking of primary PH, idiopathic PH?
And the guidelines mentioned for even this is applied for Eisenmenger also as per the guideline.
You have to go and read again.
What will happen to the pulmonary pressures if you start pulmonary vasodilator therapy? Is it the main reason we are, or what else?
Do you think her PA pressures will go down if you give vasodilators? What kind of improvement are you looking for?
Yeah, the question
is your
what
aim
kind
of therapy?
Yes.
Ma'am, the symptom benefit is significant, ma'am. Especially with the breathe trial with Bosentan has
breathe. Which breathe? There are many breathe trials.
Breathe 1, 2.
Breathe 5. So breathe 5 is the only trial that has talked of Eisenmenger syndrome and vasodilator Eisenmenger. They very categorically said about the symptomatic status and the saturations. So if she's symptomatic, really, if you think that she continues to be symptomatic, once you've treated her anemia, once you've treated her whatever fever reason she has, sepsis or whatever, only then there may be a reason to start vasodilators. Otherwise, in Eisenmenger, we usually hold vasodilators because you know what will happen to PA pressure with vasodilators in Eisenmenger? Do you think it will reduce?
No, the changes are irreversible. So the symptom benefit, all the other trials which have shown improvement are only on the 6-minute walk distance which they have quoted.
Yes, 6-minute walk distance and to some extent even saturation.
You should do.
Yes. So now we have this, scoring system for the risk in patients of PH. I don't know if they are really applicable to Eisenmenger, but only after that you should think about starting dual or single or whatever you want to start. You have to be very, categoric. Do you know what is the cost of ambrisentan and tadalafil combination?
It's costly, madam.
Isn't it? And you are going to tell her to take for the rest of her life. So you have to make these decisions very, very carefully. not casually that I will do a cath and I will start pulmonary vasodilators. These are very important decisions from patient's perspective. May not be very important from you, from your perspective.
In this patient, you don't need to do cardiac cath. You have to do 6-minute walk test as a baseline. Based on that, you should categorize whether you pulmonary vasodilator therapy is important or not. You are not going to reduce pulmonary hypertension at all. It is only functional class you are going to make it better.
Right. Yeah.
I think, ma'am, for the sake of time, I think what's the most important part of today's meeting is your presentation. So I think we thank Dr. Keur. Keur, it was wonderful. It requires guts to present on a national forum, especially in front of faculties like Professor Dr. Anita Saxena and Dr. Nageshwar to present this case. So thank you very much. And I now invite ma'am, Professor Dr. Anita Saxena, ma'am. She's a legend in her own ways. And I request her to take us through and teach us about the eisenmenger physiology, clinical differentiation between the etiologies, and whom to cath and part of that. Over to you, ma'am. Thank you.
Yeah.
Keur, can you stop sharing the screen so that ma'am can share? Yeah, please.
So Keur, thank you very much for presenting the case. I think your presentation really was good because we could have so many questions.
Yes.
If you had made a very nice presentation, we wouldn't have been discussing all that. So it's good for you. It's good for everybody else who was present. And I think some of the questions we might have answered. Is my slide visible?
Yes, ma'am, visible.
Okay, all right. So some of the things I'll just pass on simply because we have talked about that. So I will start with another case which is like your case, but this lady is not operated in the past, but she has almost same findings. She has no systolic murmur. Systolic murmur should not be there in Eisenmenger syndrome. And she was diagnosed to have Eisenmenger syndrome. Unfortunately, she wasn't yet pregnant, so we could prognosticate her and counsel her not to get pregnant because that's a relative or that's an absolute contraindication. Pregnancy is absolutely contraindicated, and that's another thing which you should tell your patient when she goes home, not to get pregnant. Very, very important because maternal mortality is very high. She's lucky to have survived this time. The next question that they often ask you is, what is the level of shunt? And we shall discuss that. With single second heart sound, it is likely to be VSD Eisenmenger. So what is Eisenmenger syndrome? It is initially described by Dr. Paul Wood. In fact, it was not described by Paul Wood. He gave this definition. It is at or near systemic level where he described pulmonary vascular resistance above 800 dynes second. Now, obviously, we don't catheterize each and every patient. So the current working definition is any congenital cardiac defect with intracardiac, and let's modify it to even extracardiac communication that leads to pulmonary hypertension, reversal of flow and cyanosis. So once there is cyanosis, you have to call it Eisenmenger syndrome. There's no question about reversibility once the saturation has gone down. So please make this diagnosis only in old children and adults and not in small babies under 2-3 years of age. And the history will be suggestive of like your case. There was history of almost heart failure and pneumonias in infancy. And later on, they may give you history of cyanosis, where sometimes the cyanosis is so subtle that it doesn't show up in the symptoms and only you diagnose it by pulse oximetry. Often they're mildly symptomatic. In fact, they remain asymptomatic for a long period of time, and only at the age of 18, 19, they come back with class 2 symptomatic status with dyspnea and fatigue. But you may get history of syncope, hemoptysis, and even cerebral stroke, like you get in primary pulmonary hypertension also. On examination, again, mild cyanosis, absence of cardiomegaly, and absence of heart failure. Like your patient had heart failure, I was a bit surprised. Generally, heart failure does not happen till they are in their mid-30s and mid-40s. Minimal or no left parasternal lift because it's usually the VSD or PDA, palpable second heart sound, constant ejection click of pulmonary arterial hypertension, absence of shunt murmurs. In fact, if you hear any murmur which is systolic more than grade 2, please don't make a diagnosis of Eisenmenger syndrome. And of course, you may have PR murmur in some patients, especially PDA. Now, the next point is, what is the level of shunt? And that is a question often asked in the exam. The age is almost the same for VSD PDA, although in ASD, perhaps it happens much later or it doesn't happen at all. Some people believe that ASD never goes into Eisenmenger. What you get as pulmonary artery hypertension in some patients, actually idiopathic PH with ASD. If differential cyanosis is present, it will help you. But remember, it is not present even in all patients of PDA, 50%. So 50% of patients of PDA will not have differential cyanosis. Therefore, if it is not present, it doesn't really help. There is no cardiomegaly in VSD PDA unless the patient has gone into the stage of failure. Second heart sound is the most important finding that will differentiate. It is single in VSD, it is narrow or normal split in PDA, and it is wide and fixed in ASD. So that is the best clue that you have, besides, of course, left parasternal and heave. So ASD you can often differentiate, but PDA and VSD become very difficult to differentiate, and you go mostly by the second heart sound splitting. Again, do not make the diagnosis of Eisenmenger syndrome in an infant, because Eisenmenger syndrome means fixed pulmonary vascular disease. Now, when we say a patient has developed Eisenmenger syndrome, it is important to understand that Eisenmenger syndrome happens over a period of time. It happens secondary to a large left to right shunt, which increases pulmonary blood flow, produces vascular remodeling, endothelial dysfunction, and of course, later increase in pulmonary artery, increase in pulmonary vascular resistance, and then reversal of the shunt leading to cyanosis and Eisenmenger syndrome. Now, it is very important to differentiate that there is a gray zone between these two clearly operable and clearly inoperable patients. And these are, some people like to call them as suspected Eisenmenger syndrome. And these are the patients that we often take to the cath table to find out the reversibility. Those who are clearly inoperable, there is no point of catheterizing patients like the one that you had. So the differentiation between hyperkinetic PAH and obstructive PAH. Now, they're both having severe pulmonary artery hypertension. It is the PVR which is much elevated in inoperable patients. So patients with hyperkinetic will still have a lot of left to right shunt, and therefore they will have cardiomegaly, they will have a large heart, they will have good shunt murmurs, and they will also have flow murmurs, which are all absent in obstructive or Eisenmenger patients. Simple X-ray can also help you. It will be cardiomegaly with plethora in hyperkinetic PAH, where PVR is almost normal or mildly elevated. And there is absence of cardiomegaly because shunt is now reversed. It has become right to left. And PVR will be elevated with central plethora and peripheral oligemia like you had in your patient. Now, generally, we say at what age you should suspect pulmonary vascular disease. Now, it is important to understand that for a straightforward post-tricuspid shunt, like a VSD, PDA, AVSD, the changes in the vascular endothelium start appearing at 2 to 4 years. In fact, some people say by 2 years of age. And therefore, everybody is expected to send these patients for closure before 1 year of age. And we're talking of large shunts. In ASD, as I said, it sometimes never happens, but if it happens in 30s and 40s usually. But patients may not present at 2 to 4 years of age. Patients often present at 10, 12 years of age. Even in Paulwood series, if you see, most of the patients have presented beyond 8 to 10 years of age. So the changes have started developing, but they may stay operable till 3, 4 years of age itself. Now, also, it is important to understand that some of these patients, large VSD and PDA, and of course ASD, can remain operable. So not that everybody born with a large VSD will Eisenmengerize. Now, when we are deciding operability, there are certain basic principles that we have to remember. One is age of the patient. If you have severe pulmonary artery hypertension, you're catheterized, everything looks as if his patient is inoperable. But if patient is 6 months or 1 year of age, likelihood is that your data is wrong and patient is operable. You also have to factor for lung and airway and ventilation issues, especially when you're dealing with patients like Down syndrome, who tend to have a lot of ventilation issues, and that can really vitiate our data and make us feel that they are inoperable. And pulmonary venous hypertension's classical example being mitral stenosis can also produce elevations in PVR, which are reversible. And in the presence of obstructive lesions like mitral stenosis, like coarctation, your data that you get in the cath lab may not be very reliable. Now, this is a classical example of an operable patient, an infant, cardiomegaly in distress, ECG showing right axis deviation with biventricular hypertrophy with good Q waves in V5, V6, and a large VSD, but going left to right. On the other hand, this is an older patient, 18-year-old lady who's visibly cyanosed, has no cardiomegaly, prominent pulmonary artery segment, typical right axis deviation with right ventricular hypertrophy, no Q waves, no left ventricular forces, and the VSD going right to left. So this is, we know, is clearly inoperable. So these two are very clear-cut cases where there are no doubt and there is no need to even catheterize these patients. They can either be sent for surgery if they belong here, or they are told no surgery if they belong to this group. However, you have an overlap in some cases where it is difficult, and these are the patients where we want to assess them for pH reactivity. And perhaps this girl at 10 years of age should have had a cardiac catheterization to decide whether she's operable or not. Now, why I was, getting a little upset when you said you may want to close her VST. It is very, very important to understand that eisenmengers live much better than patients who have been operated and were inoperable. So if you are in doubt, if you think patient has got eisenmenger or near eisenmenger, leave them alone. That is what is very important, because their survival is better than that of inoperable patients who have been operated. And this is the data from Dr. Sheila Hayward, and I'm sure this is what we also see in our routine practice. Now, before I go further, I just want to highlight over here that patients of post-tricuspid shunts are the ones who remain operable if there is severe PH also, provided PVR turns out to be low. However, in patients of pre-tricuspid shunt, even mild pulmonary artery hypertension should be taken with caution, and they may be inoperable even when the PA pressure is half systemic. So ASD with PH has to be treated differently than VSD or PDA with pulmonary artery hypertension. Now, we always talk of cardiac catheterization with vasodilator testing, but it is also important to understand that you have to take the whole picture into consideration, starting with clinical assessment for shunt murmurs, for second heart sound, cardiomegaly, ECG showing left ventricular forces, echocardiography showing good left ventricular volume overload, or if you think there is eisenmenger, do contrast echo, oxygen saturation and PO2 at rest and on exercise. And of course, this is what we call as final testing, but I'll show you there are a lot of loopholes even with cardiac catheterization. Rarely people are talking of MRI and lung biopsy, etc. We usually don't go beyond cardiac catheterization. So how do we do cardiac catheterization in these patients? Data to be collected, oxygen consumption, which is often assumed, measurements of right-sided pressures, RA, RB, PA, PA wedge, left-sided pressures, pulmonary vein, LA, LV, aorta. Conventional right and left cardiac catheterization. If you have an abnormal chamber, abnormal vessel, go ahead and take pressures there. Whenever you go to a chamber, take oxygen saturation and calculate oxygen content from all these chambers, because you will require it for calculation of QP, QS. You have to do it at baseline, then you have to repeat the whole thing on a vasodilator. Often we use oxygen, but there are other vasodilators also. What is the positive response? See, there is no fall in pulmonary artery systolic pressure because you have a large communication between left ventricle and right ventricle, or aorta and pulmonary artery. So systolic pressure doesn't fall, but diastolic pressure and mean pressures are likely to fall if the patient is operable. Similarly, because of increase in left to right flow, the left atrial pressure, which you measure as pulmonary artery wedge, may rise. QP increases, QS usually stays the same, and because of rise in QP, because of fall in mean PA pressure and high left atrial pressure, the PVR tends to fall if the patient is operable. SVR may stay the same or may rise to some extent, thereby RP over RS ratio actually falls. This is an example. You see aorta and pulmonary artery almost together, but the mean PA pressure, mean aortic pressure is higher than the mean PA pressure. And if you look very carefully, even the diastolic pressures are separating out compared to systolic, which are almost identical. Then you calculate QC, QS, you calculate QP, QS ratio. Sometimes if there is right to left shunt, you may have to calculate Q effective flow also, then PVR and SVR, and all of you know the formula for calculating these variables. Again, you have to do the whole calculation at baseline and you have to do it on pulmonary vasodilators. How do you interpret? Significance of elevated PVR will depend on patient's age. As I said earlier, younger patients, you have to be a little more liberal than older patients. If PVR is more than 6 units per meter square, that means PVRI, it's a cause for concern, at least in an older child or adult. Similarly, if RP-RS is less than 0.3 and PVR is less than 6 to 8 Wood units, it may indicate operability, again, perhaps in a younger patient. But if PVR is more than 10, it is especially sinister. Don't even think about closing this VST. Now, I'll give you an example of a 2-year-old child who has severe pulmonary artery hypertension, 78 LV pressure, 74 RV pressure, almost same. But look at the mean, 65 aortic, 45 PA pressure. If you calculate their QP, QS, you get a QP, QS ratio of quite high, 8.8 and 2.8, significant shunt, and a PVR of 3.5. So despite the fact that PA pressures are almost systemic, but the PVRI is coming out to be low because there's a huge step up from 74% to 87%, and there is no desaturation in aorta. So do we need to do pulmonary vasodilator testing in this child? No. He's 2 years old and his PVRI is quite low, 3.5, even though he has severe pulmonary artery hypertension, but his QPQS is 3:1. What are the vasodilators that we use? Oxygen, most commonly, though not ideal. Inhaled nitric oxide, if you have, and there are certain other vasodilators that have been used. A lot of people use adenosine also, especially when we are dealing with primary PH. These are some of the investigational drugs that we have also used in some patients, but not anymore. Most often, these are the two agents that are used. So what are the conventional criteria to say that the patient is operable? If at baseline PVRI is less than 6, RPS less, RP over RS ratio is less than 0.3, clearly operable. If the PVRI is more than 6, between 6 and 9, do acute vasodilator testing. But after vasodilator testing, the patient should be considered operable only if all these criteria are met. And this is obviously published in 2009. That means there should be more than 20% fall in PVRI, more than 20% fall in the ratio of PVRI to SVRI, final PVRI should be less than 6, and final RPR should be less than 0.3. So all of these criteria have to be met with before calling a child as operable. But if we are using oxygen pulmonary vasodilator, then it is important to account for dissolved oxygen, and therefore you need to have PO2 values in those 4 samples that you're going to use on oxygen, because oxygen content is hemoglobin multiplied by 1.36 and oxygen saturation. But in case of dissolved oxygen, you have to add to the content, or you have to multiply PO2 by 0.03. It is important to remember that oxygen content on oxygen should be bound oxygen and dissolved oxygen. And I will just show you an example, because up to 20% of error can be introduced by ignoring dissolved oxygen when you are using a high oxygen of FiO2 of 100%. So this is a large 16-year-old real patient with a large VSD, severe PAH, not really desaturating, 93% saturation. So we decided to cath him to decide whether he's operable or not. Good step up, 65 to 78%, hardly any desaturation, just 93%, but pressures are systemic. So in room air, his PVR came as 15 with a QPQS of 1.5. So we decided to take him up for vasodilator testing. He received 10 minutes of oxygen, and then all these samples were repeated. And you can see again, he has a huge step up of 20% here. 98% saturation in the femoral artery, PO2s, at least in aorta, we have achieved quite good, 268. So we calculated his QPQS again on 10 minutes of oxygen, and you see that the QPQS ratio has become 3.2, and his PVRI has come within operable range. So you might feel very happy that he's operable. Remember, he's 16 years old. So what we did is we took the dissolved oxygen into consideration based on the PO2s that we have here, and you will see that when that was brought into the equation, then the PVRI increased to 10. So this was an error that we would have missed if we had not taken dissolved oxygen into consideration. So obviously this patient was not advised to undergo VSD closure. So he's not clear-cut eisenmenger because he's not cyanos, but he's almost going there. And these are the patients where you have to be extremely careful when advising them surgery or not. Nitric oxide, we don't have much experience, but I think some centers have started using it, and it is supposed to be a little better than oxygen alone, but obviously you have to use it with oxygen. And this was the data I was showing you. Other methods to test pH reactivity in the cath lab, one of the other way that we do in PDA is to occlude the PDA. So you take a balloon, you occlude the PDA, and then take the pressures. And these are arbitrary criteria that have been published, that if you have more than 25% fall in PA pressures, more than 50% fall in PA and aortic diastolic pressure, like here you see that both pressures are equal after you block the PDA with a balloon, then you see them separating. I'm not very sure if it's a very good way of knowing. And I think there is some data from Sri Chitra where they've shown that this is also not a full proof to say whether the patient is operable or not. One more thing that a lot of us have started using is arterial PO2 on exercise. So if you have somebody who has a saturation of, let's say, 95% or so, it looks like eisenmenger, you ask them to do a little bit of exercise and the saturation falls to less than 90%, maybe it is a marker of inoperable, but I wouldn't really give up at this stage. If the child is 16, 17 years, maybe I will, but if the child is 2 years, 3 years, I will still go ahead and catheterize to get the PVRI. Obviously, its sensitivity and specificity has not been tested in large studies. Now, before I go, I just want to show you a couple of caveats that we've had when we are testing for reactivity. This is a 9-year-old boy who came with clear-cut cyanosis and dyspnea, and echo showed large VSD, severe PH, right to left shunting, but with severe mitral stenosis. And this is the data. You can see that his pressures are systemic and his PA saturation is only 62%. There is hardly any step up, and he is deeply desaturated. But look at his PA wedge. His PA wedge was huge, 38, because of severe mitral stenosis. Despite that, his PVRI came as 22. So, and this diagnosis we obviously had by echo. His mitral area was only 0.5 centimeter. So we decided to go ahead and operate on him. The plan was whether to just do mitral commissurotomy and come back. But our surgeon said that he's not going to make it if we do half the work. So they decided to do VSD closure as well as mitral commissurotomy. We restarted him, I think, couple of maybe 6 weeks later, and you can see that his PA pressures have really come down. His PVRI is still very high, but we were hoping that after another 6 months, his PVRI will also go down to normal level. This is another 8-year-old boy who came with features of fever, abdominal distension, etc. He was a case of large VSD, but surprisingly, he had features of constrictive pericarditis, and he was also blue. And you can see his X-ray, absolutely calcified pericardium. So this is large VSD, and you will see that most of it is going right to left in this child. Hardly any LV volume overload he has. He also has a small muscular VSD here. So he was a case of CCP, whether he also has Eisenmenger syndrome because he was cynos. So the dilemma was, what should we do? Should we just do pericardectomy or pericardectomy and VSD closure or reassess? So we talked to the surgeon. This case has actually been reported. If you see the data initially, he's quite desaturated, becomes 85% on oxygen, severe pulmonary artery hypertension, very high RA pressure because of CCP, very high PVRI as well. So he just underwent pericardectomy because it was not an open heart procedure. So he could have a pericardectomy without going on bypass. 3 months post pericardectomy, his saturation had improved significantly, became 99%, although his pressures are high, expected to be because there is a large VSD. His LA and RA pressures have also, at least RA pressure has gone down significantly. LA is still high, and his PVRI became 3.8 on oxygen, and that gave us a feeling that he should undergo VSD closure. So he did undergo VSD closure, and post 10 months VSD closure, you can see that his PA pressures are now almost half systemic. He's fully saturated. We haven't done an oxygen study, so his PVRI is still on the higher side, and hopefully it will go down further. So this was pericardial constriction, which was almost a cause for reversible Eisenmenger physiology. Why I'm showing these cases? It is important to remember that obstructive lesions or coexistent lesions with Eisenmenger may modify the hemodynamics. So one has to be careful. Same is going to happen with coarctation of aorta also. So to conclude, determining operability is important for patients who have severe pulmonary artery hypertension and post-tricuspid left to right shunt. But a comprehensive evaluation, which includes clinical assessment, echocardiography, X-ray, ECG, and in some cases cardiac catheterization is needed. Don't depend on one investigation alone. Role of vasodilator testing in predicting long-term outcome remains questionable, although we do it every day. But again, when in doubt, do not send patient for surgery. And I'll end by this example. This is an 18-year-old girl who underwent closure at, I think, 4 years of age. Now is back with severe pulmonary artery hypertension, severe TR, dilated right ventricle, in fact, dysfunctional right ventricle, class 3 symptomatic. When we looked at her data, her basal QPQS was 1.7, became 2.8. Her PVRIs went 9.5, became 5.5. But obviously, this was not a right decision. Thank you for your attention.
Ma'am, it's a really wonderful, and we noticed similarly several cases coming with Eisenmenger syndrome getting converted into idiopathic and all. Recently, one patient, AP window, closed sometime 15 years back. One of the institute came with gross right heart failure. We had to fenestrate his septum and all. You have shown a lot of examples and wonderfully described. Thank you very much. Your very, very lucid presentation.
Thank you, ma'am, for the wonderful presentation. Yes, we, as Dr. Rageshwar is saying, we also came across a lot of cases. One young male, 25, about to get married, cath done that day, probably that there were some transducer issues. The other unit, PA pressures found to be in the range of 50s. a device closure done. He didn't want an NASD, he didn't want a surgical closure fenestrated, which was proposed by one of the group, and then ended up with a device closure and comes back after his marriage with the fulminant right heart failure. So we do come across these kind of scenarios, and it's often missed. And then you have to think of either removing the device. Now the patient doesn't want to get it removed because he thinks it is going to give a scar, which he doesn't want to show his wife. So a lot of social stigmata also go along with it, and that's how sometimes device closures can actually end up complicated in a patient who's got a borderline PAH. So wonderful examples and a wonderful talk. Majan sir, Professor Dr. Ajay Majan sir.
This is exactly the very important talk. All PG students must understand when there is any borderline case of eisenmenger physiology, we have to deal with, or when we are suspecting eisenmenger physiology, we have to take at least a cath study. You have to define the reversibility, and then only we have to give the opinion regarding the surgery. So to give the opinion regarding the surgery is the very important question, and we wrongly give any opinion regarding closure of this device defects, then we might land up with the problem. This problem is absolutely related to the severe pulmonary hypertension with RV dysfunction, and life become miserable for the patient. So the whatever is shown by Professor Dr. Anita Saxena madam, they are the very important cases or patients, and always we have to think about these conditions when somebody comes in OPD or in department for the opinion. So to give the opinion in congenital heart disease is a difficult scenario, and we have to do cath studies, discussion, and we should not hurry in giving the opinion or giving the decisions. It should be discussed in detail with the in cath conferences. That's my take on this talk.
Absolutely.
Yeah, any message, Dr. Rao?
I think there are a couple of questions in the chat box, but madam had already answered them. One was on PPDCM residual shunt, role of cath. I think we discussed and deliberated a lot on it. And RV dysfunction, should we start vasodilators? Again, which was very well covered by both Professor Dr. Anita Saxena ma'am and by Dr. Nageshwar as well, as to whom to give, what to give, when to give, what does it improve. So all the three questions are beautifully covered. I think there are no more questions in the chat box. Closing comments, sir, Dr. Majan sir, and then we can hand over the session to the either Dr. Parthasarthi or Kanu can wind the session.
I think we need the lecture of Professor Madam Saxena madam's lecture with each and everyone to re-refer it frequently, because it is most required thing for all of us.
Yes. Okay, sir. Dr. Rao, you like to add any points, Dr.
I think from the student point of view, one important thing is write down a dummy case sheet. Like auscultation, when you are doing, describe the first heart sound, second heart sound, whether third is there or not, fourth heart sound, then any additional sounds. In your presentation, the heart sounds are not described well, and we did not even discuss ejection click is there or not in this. So I expect those findings to be discussed, whether it is there or not immaterial. So that's why a systematic, if you present that, you will not miss. You can be wrong in defining the finding. That is not the important aspect. Whether you are actually following the protocol of presentation is very important. That is the only message which I want to take. Either it can be X-ray, ECG, echo, or clinical presentation. You have to go by the format.
Yes, sir.
Shall I conclude, sir?
Yes, sir. Thank you, sir.
Okay. So first and foremost, is my deep gratitude to Anita ma'am and Dr. Rao for showing such a passion and involvement on this subject. I'm sure Dr. K.O. Ratter has really, presented the case nicely and handled the questions also in front of eminent pediatric cardiologists. It's a very tough call, I know. So first of all, again, I want to thanks to as usual, our Kamal Sharma sir and Dr. Mahajan sir for sharing their insights and making this program really interactive and quite informative for the students. And so I hope the student will largely benefited from today's program and encourage further to participate actively the coming every Saturday program which I have planned. With that positive note, let's conclude. Good night, sir. Thank you, sir, once again.
Thank you.